everyone, Dr. Priya here. I wanted to make this hopefully short and hopefully simple video which aims to demystify the dexamethasone suppression test. This is a test that is actually of a lot of utility if you do have a patient with Cushing's syndrome or suspected Cushing's syndrome. And it is actually very simple to understand, but it is one of those tests that for some reason a lot of medical students just fear, and I think that fear just blocks you from being able to understand it. So let's hope that by the end of this, you are convinced that dexamethasone suppression test is actually really simple to understand. Okay, here we go. So we're going to start off with the basics of the dexamethasone suppression test. So first off, the two big questions: what is it for, and how is it done? Okay, so what is it for? It is basically a test that you do in order to help you to identify the likely reason why a patient has elevated endogenous cortisol levels. When you say basically you already know your patient has high cortisol levels, and endogenous means that cortisol is coming from somewhere inside their body. It is possible for a patient to have elevated glucocorticoids from sources outside the body, but you should be able to figure that out from your history, assuming you've established enough rapport and your patient is telling you the truth, to know that if that high glucocorticoid is coming from somewhere else. So if you are using this dexamethasone suppression test for this reason, the implications would be that A, you wouldn't do a dexamethasone suppression test unless you already have a good reason to suspect that your patient's basic cortisol levels are high. And the other thing is that you need to know that this cortisol is coming from inside your patient rather than from outside. And usually a patient on high-dose steroids strong enough to give you symptoms of excess glucocorticoid are usually on it for a medical reason, like autoimmune diseases or nephrotic syndrome, where you need high-dose corticosteroids for a certain period, and after which they will usually be weaned down. Other sources that I've mentioned there are a lot of possible places a person could get steroids. If you are thinking of a local Asian context, you do need to be aware that many powdered medications that you obtain from traditional healers, especially for joint pains and muscle aches, may often actually contain corticosteroids. Okay, back to the dexamethasone suppression test. How is it done? Basically, you need to take your patient's baseline cortisol so you know that it is high. And once you have that baseline measurement, you give the patient your dexamethasone. Usually it's given orally, but there are variants to the test. And after a certain defined period of time that the dexamethasone has had to work, you will recheck the cortisol level and see if giving dexamethasone was able to suppress that high cortisol level. Okay, so basically that's how it works. Okay, so before we go any further, we're going to do a quick recap of the HPA axis, which stands for the hypothalamic pituitary adrenal axis. Okay, so let's go. So you've got the hypothalamus, the pituitary, and the adrenals. In this case, the adrenal cortex. So we're going to do this step by step. Okay, so the hypothalamus is actually the big boss, and it tells your pituitary what to do. And how the hypothalamus talks to pituitary in relation to cortisol synthesis is through releasing CRH, or corticotrophin releasing hormone. And then the pituitary, under the stimulation of CRH, releases ACTH, adenocorticotropic hormone, which will then travel via your bloodstream to reach the adrenal cortex. Just a quick image, you've got here the kidney. Above the kidney you have the adrenal gland. The adrenal gland in turn actually has an outer cortex and an inner medulla. The outer cortex is the endocrine portion. The inner medulla, if you remember from other physiology classes, is actually part of your autonomic nervous system and releases hormones related to the sympathetic arm of the autonomic nervous system. But back to cortisol. So you have hypothalamus releasing CRH, which tells the pituitary to release ACTH, which then travels to your adrenal cortex and tells your adrenal cortex to release cortisol, which is the main hormone of interest in our current discussion. That cortisol is then released into the bloodstream, but it travels all around your body and does whatever it's supposed to do, which you will know from other portions of your learning. Right. So the main hormone of interest here is cortisol, and cortisol is what actually exerts its effect on your body. So what you eventually want to do in order to maintain function of your body is to have an appropriate level of cortisol. So you want to use the amount of cortisol in your body as feedback to the hypothalamus and pituitary. So when there is cortisol in the bloodstream, it exerts a negative feedback effect on the hypothalamus and the pituitary. So when you have a lot of cortisol, you would expect that you would have suppression of CRH and ACTH. So under normal physiological conditions, cortisol is produced in the adrenal cortex, and it is produced under the influence of ACTH. And the cortisol then exerts this negative feedback on the hypothalamus and pituitary. So this is the whole feedback loop, how you regulate your cortisol levels. Okay. So when you have dexamethasone, and this whole dexamethasone suppression test, dexamethasone is a potent glucocorticoid. So if you give external dexamethasone, it actually has the power to have that cortisol-like effect in the sense that it will suppress your secretion of ACTH and also CRH, but your main interest here is ACTH. However, the nice thing about dexamethasone in the context of doing this test is that even though it has this effect of suppressing pituitary secretion of ACTH, it will not be detected on a blood test for cortisol. So you can measure cortisol independently of dexamethasone, which is going to be relevant when we look a little bit more at the dexamethasone suppression test. Okay, so we're still looking at the same diagram, but this time we're going to be talking about a slightly different point. And this relates again to why you do a dexamethasone suppression test, because you do it in a patient where you know they have high cortisol, and you want to use it to help you figure out where that cortisol is coming from. So let's just kind of talk about this. Cushing syndrome I've mentioned here, which is basically the condition where you would be doing a dexamethasone suppression test. And it is essentially a condition where there are excess glucocorticoids in the body. And if those glucocorticoids are coming from an endogenous source, then it's going to be cortisol. If it is an iatrogenic kind of Cushing syndrome, then you could be taking a variety of other glucocorticoids. So the two big questions you want to ask yourself when you're trying to diagnose Cushing syndrome of endogenous origin is, where is that cortisol coming from and what is triggering its release? And dexamethasone test is actually going to help us figure that out. So just as a quick recap before I move to the next slide, essentially we already know cortisol is synthesized in the adrenal cortex. Under normal circumstances, it needs the stimulus from ACTH in order to be produced. However, you can have some conditions where you have benign tumors of the adrenal cortex, which autonomously secrete the cortisol without needing ACTH. And you will see later how this could have an impact. The other thing is that you could have a problem where the primary problem is the cortex has gone bananas and it's just releasing too much cortisol. But you could also have a problem where your pituitary is the issue and it is over secreting ACTH. So when you have too much ACTH, that will in turn produce an excess stimulus on your adrenal cortex to produce cortisol. And that is usually from a benign tumor and some sort of adenoma in your pituitary that is over secreting ACTH. And those generally don't have the same kind of level of sensitivity to negative feedback from cortisol levels, so you end up with a high level of cortisol. And we'll move on to look at how we can interpret the whole picture of a dexamethasone suppression test in the next slide. Okay, here we go. So this is, the final slide and the most important one, and probably the one that everybody thinks that it looks horribly complicated. But give me a chance, and I'm going to show you at the end of this. You're going to be saying it's so easy. Okay, so here we go. You do a dexamethasone suppression test when you have high levels of endogenous cortisol. Otherwise, there is no point doing this test. And there's two different doses of dexamethasone you can use: low dose and high dose. The details you can look up elsewhere. Okay. But essentially, after you give the dexamethasone, whether it's low or high, the outcome you're looking for in your patient is whether when you gave the dexamethasone, were you able to suppress their cortisol level, or is the cortisol level still high? Okay, so let's start off by looking at the low dose dexamethasone. If you had high endogenous cortisol, you give a low dose dexamethasone, you give the patient some time for the dexamethasone to get into the system and do what it needs to do. If you are able to suppress the cortisol with a low dose dexamethasone, that usually implies that that high level of cortisol that was there in the first place actually had a physiological cause, because you are able to suppress it quite easily with the low dose of dexamethasone. And one of the most typical reasons you would give for this is some kind of severe physiological stress. Maybe exams in your case. Okay, right, but if you give low dose dexamethasone and your high levels of cortisol are still high, so you failed to suppress it, then you know that your patient truly has Cushing syndrome, a pathological cause for the high cortisol. So usually this low-dose dexamethasone is kind of your screening test to try and figure out whether your patient truly has Cushing's syndrome or not. So once you've done that and you know cortisol is still high, you will proceed to do the high-dose dexamethasone, which will then help you to try to further delineate the cause of your elevated endogenous cortisol, and will then guide your further investigations as well as your management. So when you give the high dose, again, you have the same two outcomes. Either you suppress your cortisol or your cortisol remains high. So if you are able to suppress the cortisol, then actually what your patient has is almost certainly, in medicine there's almost never and almost never, always or never, sorry. So you're thinking Cushing's disease. And Cushing's disease is a specific type of Cushing's syndrome where it is caused by a benign pituitary tumor which secretes ACTH. And as we just talked about earlier, ACTH will induce your adrenal cortex to secrete lots and lots of cortisol. But the thing is, when you gave this tumor, it is still pituitary tissue. It is not 100% normal pituitary tissue, so it is functional at secreting ACTH. It was not able to be suppressed with low-dose dexamethasone, but it is still able to respond to some degree of negative feedback when you have a lot of glucocorticoid. So when you give a high-dose dexamethasone, you are able to suppress that tumor's function and suppress ACTH secretion, and therefore reduce the secretion of cortisol from the adrenal cortex. So you will see suppression of cortisol. Okay, so on the other side, if your cortisol levels are still high, then you need an extra step to make sense of this. You want to know if the cortisol is still high, is that happening in a setting of low ACTH or high ACTH? So basically, if you have high cortisol but low ACTH, that indicates to you that HPA axis, your cortisol is effectively suppressing that pituitary axis. So it means that pituitary is responding to the cortisol, but the cortisol is coming from something that is not dependent on ACTH anymore, and that's usually a cortisol secreting adrenal tumor. On the other hand, if you have high ACTH, then this is no longer anything to do with the physiological axis, and this is usually an ectopic source of ACTH. And one of the classical ones is usually a small cell carcinoma of the lung, which actually secretes ACTH. Okay, so this is by no means a full or complete explanation of anything and everything to do with dexamethasone suppression test, but this covers the core basics and should be enough for you to understand the basics of what you need to know at year 2 level. And I hope this helps you guys figure things out. Okay, and hopefully you really agree by now. It's really easy. Take care, guys. Bye.